So today we have, 4 topics to consider really. We talked about need already a little bit. Professional judgment, use, and does use reflect need? And these are all few quite crucial interrelationships. Hopefully our model has started to help us think a little bit about where things sit. First of all, we'll talk about need a little bit more. Need for health, just to recap, is a felt need, subjective. And in order to be able to understand it, there's no other way to get to it unless we do population self-assessment surveys and a bit of objective measure. Like you can send in clinicians to people's homes to observe people's mobility, for example, or you ask the patient to say, can you report how much you can walk? And often, clinicians take history purely to get the people's assessment of their health, or the needs for their health. So this is how we get evidence from epidemiological surveys. Okay, and the need for healthcare, normative need, is all of the above, plus a clinician knowing, this is crucial, knowing the knowledge of the appropriate use of care. So what if there is an effective treatment out there? So in places where there's no effective treatment, you don't know what's best to do, then there's no need for healthcare because there's nothing to solve that person's issue. There's also an understanding of cost effectiveness here. So, we might have osteoarthrosis or osteoarthritis, and you might see it very obviously in an X-ray. And the patient can be reporting symptoms like, I can't walk up the stairs anymore, doctor, and it's not very comfortable, I get a niggle. And the doctor says, yeah, you have osteoarthritis. But when does that turn into, yes, you should have a hip replacement. I think you should have one now. That's a risk benefit judgment, that's a cost effectiveness judgment. That's when is treatment better than no treatment? That's crucial. So that's why we say the above plus knowledge of appropriate care. We might think that's black and white, but actually for about 80% of healthcare, we actually don't know necessarily the cost effectiveness, but we don't know the effectiveness, let alone the cost effectiveness. So actually for most of care, it's actually dependent on a lot of things, time and place, and clinical judgment, most of all. It's also dependent on understanding of the best treatments as well. So with new clinical guidelines and things. For example, so high-income countries, it varies between countries. So high-income countries, it is now shown to be most cost-effective and effective if you have a heart attack, time of your heart attack to a PCI center within 90 minutes. And that's exactly what you want. So it's most cost-effective if you have a heart attack to send them to a major center and get them into a catheterization lab to open up their blood vessels again within 90 minutes. Now that's expected in England. That we do that with our EMS services with our patients. Most cost-effective care been shown, best for patients, and best for the health services. However, if I was in rural India, I wouldn't expect that. I shouldn't expect that same level. So it's dependent on how much you spend as a health system, health service, technology, and what is the understanding of the day in scientific evidence, and what is affordable. And that is dependent on the willingness to pay. Threshold is dependent on the value judgment the country puts in on health. So just to be mindful that these things are more complex and have a lot more than one meets the eye. So let's move on to some evidence and some studies that show this in context. What does it really mean? So this is a really interesting study that shows us the decision to screen for AAA, for abdominal aortic aneurysms, from America, UK, and US. So now, scientific evidence that underpins when you should screen or whether you should screen for AAA is the same. So these 3 countries use the same scientific literature. It's a multi-center country study. And can you see the variation in how the decisions are made to screen? So what they've decided to screen for AAA. Same evidence base, but for the UK, they decided to only screen men between the age of 65 to 74. And for Canada, they also decided to screen women above the age of 65. But UK, we don't screen women at all. And in the US, not only do they screen men between 60 to all the way to 85, women as well, and also men. So they've decided on quite different things and who to screen and who not to screen, based on the same literature resources, literature evidence base. So it reflects the decisions reflect what is most cost effective at the time. And now me and you sitting here, we can't really decide who's right. Who's to say America's doing it best? Is Canada doing it best? They're doing, at least they're doing women too. Or is UK actually most cost effective because the evidence suggests that you should only screen men and actually all those women don't actually really need to be screened. So we can assume, but only, we can't really say who's right and what's wrong. Also it reflects how much the country is willing to spend and the resources they want to put in. Okay. This is also very interesting, a slightly older study now, but this group have looked into grey literature and policy documents of very different social insurance schemes. So all these countries have a commonality: France, Switzerland, Germany, Luxembourg, Israel, Netherlands, and having a social insurance, and they provide standard packages of care. And they've looked at what is provided across all these countries. So there's some universal things. Then the interesting thing is they've also looked at some controversial treatments that only some countries provide and others don't. For example, some countries, so what's called controversial? It means that these 6 countries don't all provide dental care in their standard package of healthcare. So they don't think dental care is necessarily needed in there. But we might go, oh, interesting. Something dental care should be included, should it not? That's a big debate. Germany. Is the only country that offered spa treatment, spa care. Now, I don't know if in Japan, whether spas, I know hot springs are very popular. Spa care, is that in the spa health? Should that be provided in a universal package of healthcare entitlement? But in England, if we thought about spas, we think about, very luxurious. It's definitely not healthcare. But in Germany, that was at that time that was provided as part of the insurance scheme. So, whether it should be fundamental entitlement, none of these are really fixed. And this is probably a combination of behavioral beliefs about health, what a cultural country context perspective feel that is beneficial to healthcare, and the impacts, combination of those. We don't, sitting here, again, we can't really put a judgment on whether it was right or wrong. So it's quite interesting. There's 2 other types of need that we should actually be aware of. In the literature, we have something called relative need, which is when actually a lot of countries and a lot of places use a lot, because we don't actually know the need. We mentioned the difficulty in measuring need. We need to use population surveys and the incidence and prevalence. So when we don't actually know the true need, we use our relative need, which is comparing with similar populations. And we are making some assumptions. We are trying to understand that one incidence and one prevalence in one population is similar. We also don't know exactly how effective a lot of the treatments are we mentioned. So how cost effective, how effective, maybe only about 20% of interventions. We know definitely that there has been health technology assessments more effective, cost effective in studies. So that's why planners usually use a relative need. So, my neighboring city is doing this much, is seeing this much need. Yeah, I think that's probably the right amount of need. So what we do, what we offer, what we say is need, is a combination of all these different things: wisdom, experience, belief, cultural. There's nothing that's uniform in this. Similarly, sometimes some textbooks call some say express need, and that essentially is demand or normative need. They say express need is the demand for